All right. So I'd like to welcome everyone to our February 2025 installment of the Global Neurosurgery Committee of the World Federation of Neurosurgical Societies Research Group Journal Club. Okay, so we are a subcommittee of the Global Neurosurgery Committee focused on advancing research and scholarly work in global neurosurgery. And I'm joined by several giants today, and Dr. Ignatius Esene, who's going to be introduced by Dr. Alvin Ukachukwu, will be our presenter. So, without further ado, I will take myself off camera for now, and I will share an introductory slide to help Dr. Ukachukwu um, introduce our speaker. Okay.
Thanks, Ernest, and glad to have you here, Franco and Ignatius. It's my pleasure to introduce our speaker for today, Dr. Ignatius Esene, who is well known to many of us in the global neurosurgery field. So Ignatius is a Cameroonian neurosurgeon scientist, as well as a public, international, and global health physician. He's currently a senior lecturer and consultant neurosurgeon at the Faculty of Health Sciences, University of Bamenda in Cameroon. Ignatius obtained his basic MD degree from the University of Yaoundé in Cameroon before proceeding to Belgium, where he obtained an MPH. Subsequently, he did his neurosurgery residency in Egypt, obtaining both the MSc and PhD degrees. He also had several postgraduate training opportunities in health economics, advanced research methods, as well as international health, as well as a fellowship in skull-base and cerebrovascular surgery at the University of Wisconsin in Madison. Ignatius has been the chair of the WFNS Young Neurosurgeons Forum, as well as the CANS, that's the Continental Association of African Neurosurgical Societies Young Neurosurgeons Forum. He's the immediate past Secretary General of CANS, and he's currently the Secretary General of the Cameroonian Neurosurgery Society, as well as the chair of the Young Neurosurgeons Forum of FIENS. Ignatius is also the co-founder and deputy editor-in-chief of the Journal of Global Neurosurgery and the Pan-African Medical Journal, Clinical Medicine, and he's an editorial board member of several high-ranking neurosurgery journals, including Neurosurgery, Acta Neurochirurgica, and the WFNS Journal. He is also the founder and CEO of Winners Foundation, which is dedicated to global health, global neurosurgery research and training and education opportunities. His main interests, of course, are global neurosurgery and research methods in neurosurgery. Ignatius, we're proud to have you here. I'll hand over the moderation to Professor Franco Savade.
Hello, welcome to everyone. And I know Ignatius since the time in which I was the president of the World Federation, and he was leading with at least a lot of strength and vision for the future, the Young Neurosurgical Forum. So I follow his career. And today we are going to discuss a topic, it's a hot topic. The topic is not exactly, let's say, review and meta-analysis. So the topic, how do we do it? And Ignatius, what we want from you is to understand how they can be helpful for clinical practice. Publication for publication is a theoretical exercise. As Harvey Cushing was saying 100 years ago, we work, we operate, and we publish to make the other doing as we do. So we need a practical spirit when we do this difficult exercise, like let's say a systematic review or a systematic meta-analysis. So Ignatius, I'm sure your presentation will be as good as your paper, and we will have time for discussing it.
Thank you so much. Let me share my screen. Good afternoon to everyone. It's a great honor and pleasure for me to be here this afternoon to talk about something which I'm very passionate about. I want to start by thanking my very good friends, Ernest and Alvan, for inviting me to present this talk to young neurosurgeons and future neurosurgeons, and also senior neurosurgeons who are interested in evidence-based medicine. Of course, Ernest, I've known Ernest for quite a very long time. I know he's passionate about global neurosurgery, especially in combating inequities in global neurosurgery. Alvan is a very good friend of mine, and if there's one person you have to pick from Africa to talk about global neurosurgery, I think he should be the one, because he has extensively worked on it and has proven himself to be a leader in the field of global neurosurgery, not only in Africa and worldwide. Franco is a mentor, and I'm so honored to have him here today to moderate this session. I want to acknowledge the presence of Professor Gail Rousseau, with whom we've been working together in things. So my presentation is going to be based on three papers, one which I published in 2016 about research methods in neurosurgery, because when I was studying neurosurgery as a resident, I found out that sometimes it was difficult to understand a few concepts in textbooks in neurosurgery. So I started investigating why we have some of these difficulties and tried to provide solution to this. And a few years later, I noticed that neurosurgeons had difficulty not only in conducting systematic reviews and meta-analyses, but they had difficulty in interpreting them and translating information in systematic reviews and meta-analysis to patient care. So we wrote this commentary, and last year we published this paper in ACTA when we were invited by the editor-in-chief, Professor Tim Matheson, to provide a pragmatic approach to interpreting systematic reviews and meta-analysis. So here we have four papers, and it might be difficult for anyone to say which of them belongs to. It's a paper that can be classified as a paper of global neurosurgery, and which of the papers can be classified as that of traditional neurosurgery. So it's very difficult. There's no well demarcated boundary between clinical neurosurgery and global neurosurgery. So that's why a few years back, we wrote this paper with one of my very good friend, Eric, trying to define what global neurosurgery and the scope and the practice of global neurosurgery, because it is, if you look at in the past, the definition of global neurosurgery was referred to as humanitarian neurosurgery, where maybe experts from high-income countries used to go to low-income countries to help and to assist and provide aid. But over time, this definition changed, and we started asking our question, what is the definition of global neurosurgery? There's this definition which is widely accepted, which defines global neurosurgery as the clinical and the public health practice of neurosurgery. So what does this mean? Most neurosurgeons practice clinical neurosurgery or traditional neurosurgery. So they focus on treating patients. It might be a pediatric neurosurgeon. A neurosurgeon focus on traumatology like Ernest. People focus on endoscopic surgery, spine surgery, functional neurosurgery, and even skull-based. But the concept of global neurosurgery is a concept which is holistic. So a neurosurgeon who is not only involved in providing traditional neurosurgery, treating patients, but is involved in the public health practice of neurosurgery. So besides clinical practice, it has been extended to include education, research, advocacy, and policy development. But we all know that the practice of neurosurgery today is guided by a paradigm shift which was developed in the early 90s, which is the concept of evidence-based neurosurgery, and that of public health neurosurgery by evidence-based policymaking. So therefore, we can conclude that global neurosurgery should be practiced based on evidence. So what is this evidence? We know evidence, they talk about evidence takes us to a concept of evidence-based neurosurgery, which has been defined as a conscientious, explicit, and a judicious use of current evidence to provide care about individual patients. But we know this is mostly focused on traditional neurosurgery. We'll talk about global neurosurgery, which is mostly about policies. So we have four parameters or four tools, which are the integration of the best research evidence available, the practitioner's expertise and experience, the values of the population in defining policies to improve on the healthcare of the population. So, and we know that systematic reviews and the meta-analysis are at the pinnacle of evidence-based medicine. So therefore, why are systematic reviews and meta-analysis very important, or why are they at the pinnacle? Because they are studies conducted with much rigor. The qualities are very high, and they are reliable and reproducible. So for us to provide optimal care to patients, for us to develop good policies in global neurosurgery, we have to rely on studies that provide reliable information. So what are systematic reviews and meta-analysis? In 2016, we published this paper in which we looked at we provide an overview of all the study designs in neurosurgery. So we know that globally, quantitative research designs in neurosurgery can be descriptive or analytic, okay? But there's another group of studies known as integrative studies, and this is where systematic reviews and meta-analysis belong. So sometimes when you bring quantitative studies together and provide just a narrative summary, we talk about systematic reviews. But if we pull them statistically, especially studies that are similar quantitatively and produce a summary value, then we talk about meta-analysis. Systematic reviews and meta-analysis belong to a wide group of family of studies called the reviews. Okay, they start from the traditional review, where an expert comes out with, based on his experience, can summarize current evidence to give a direction or to close up the gap that is existing in the literature through scoping reviews. And then we have systematic reviews, which are very common in all the specialties. And then we have the particular kinds of systematic reviews, which are called the Cochrane systematic reviews. Here, they are very high quality because when the producers of this kind of systematic reviews need to provide a protocol which is published before the systematic review is being carried. And then we move now to meta-analysis, which involves the quantitative summary of systematic reviews. And then quite recently, we talk about overviews. Overviews are systematic reviews of systematic reviews and meta-analysis. Again, we need to distinguish between systematic reviews and meta-analysis and other kinds of reviews. If we summarize qualitative studies, we talk about meta-synthesis. So if it's a summary of quantitative studies and quantitative studies, we talk about meta-summaries. So meta-analysis involves just quantitative studies. So today we cannot talk about all the different kinds of systematic reviews and meta-analysis. So we are going to focus on the ones which are relevant to global neurosurgeons, which are called aggregate data meta-analysis, like studies summarizing the incidence of diseases, studies looking at the prevalence, looking at the burden of diseases. These are called aggregate data meta-analysis. So when you look over time, you realize that the number of systematic reviews and meta-analysis in literature has been increasing gradually. So the number of studies also in global neurosurgery. So this is a rapid search which I did in PubMed, and you see that there's a constant increase in the number of systematic reviews and meta-analysis published in global neurosurgery, which parallels that of those published in neurosurgical literature. So this shows that systematic reviews and meta-analysis are very important. It is a very good way of summarizing evidence to help busy neurosurgeons to be able to extract data and apply in patients. So our discussion today is going to focus on this paper, which we published last year. It's true that with our experience over the last decade, most neurosurgeons, when we go to give lectures, most neurosurgeons acknowledge that they don't know how to conduct a systematic review and meta-analysis. And most of them also tell us that they have difficulty in interpreting them. Talking about conducting systematic reviews and meta-analysis, it's a very huge topic. We can't talk about them today because there are so many kinds of systematic reviews and meta-analysis. There are those related to etiology, those related to diagnosis, those related to therapy, those related to prognosis, economic analysis. So we can't talk about them in a few minutes. I'll just give a brief summary of what systematic reviews and how they can be conducted, and then I'll focus on our topic of today, which is interpreting systematic reviews and translating information in systematic reviews and meta-analysis into defining policies, which is important for global neurosurgeons. So doing a meta-analysis is very easy, but doing a good one is very hard. We start to do a meta-analysis or systematic review, we need to first of all define the research question. This is the core, this is the key. You need to define a good research question. If the question is poor, the meta-analysis is not going to yield any useful information to us. So the classical tool used is the PICO. So I'm not going to go into this. As I said, I'm just going to briefly outline the steps. After defining the research question, you define the search strategy, because if you select data, if you in looking for information, if you take data and leaving out important studies, the summary outcome is not going to be generalizable. It's going to be biased. It's going to be skewed. For example, if you're looking at traumatic brain injury and you search in PubMed, you might miss a lot of papers that are published in LMICs because their databases are not, their papers are not indexed in big databases. So the conclusion drawn from them is not going to be applicable to neurosurgeons in LMICs. So you need to do a proper search and search in relevant databases. After that, you extract the data and so on and so forth. And one of the things which is very important is you have to assess the quality of the study that have to be included in the systematic reviews and meta-analysis, as well as thoroughly evaluate the methodology of the systematic review and meta-analysis and the way it has been reported. These are tools that have been developed again. As Professor Franco said, this is not a theoretical lecture, so we are not going to go into this. I will mention this later on during my presentation. So once we've assessed for risk of bias, assessed the quality of the systematic reviews and meta-analysis, we synthesize, analyze, and it is published. And most often we recommend that this systematic reviews and meta-analysis be updated regularly because science changes. So having understood the brief steps in conducting a systematic review and meta-analysis, we'll focus on interpreting systematic reviews and meta-analysis for global neurosurgeons. So in our paper, we summarize 5 basic steps. To interpret a systematic review and meta-analysis, the first thing you need to look at what are the characteristics of the patients, okay, or the characteristic socio-demographic features of the studies included in systematic review and meta-analysis. So a table is always presented where the title is identified, the study, the year, the site, the period, the sample sizes of all the studies included, and other relevant socio-demographic features. The next thing is need to define is the effect size, that the kind of data that you are going to analyze. For global neurosurgeons, the most common type are what we call the unary data. That is, for example, if you are looking at the prevalence of a disease, you are looking at the incidence of a disease, this is the kind of data that might be interesting to global neurosurgeons. For traditional neurosurgeons or for clinicians, they are interested in binary data. For example, if you are comparing the complication rate between 2 techniques, okay, or look at the complication rate, absence or presence of a complication using 2 techniques, then this is quite interesting. Another kind of outcome, which is often neglected in neurosurgery, which you find very common in clinical epidemiology, are the continuous outcomes. For example, you look at intracranial pressure, okay, after maybe how does it change? After putting a patient on treatment A or treatment B, then you need to be able to know how to pull these kind of studies. You look at the length of hospital stay. Okay, you need to know how to do this kind of continuous outcome meta-analysis. The data in systematic reviews and meta-analysis is often presented in forest plot. Why forest plot? Because tables are very cumbersome and it's difficult for someone to extract meaningful data from the tables. So therefore, there are many ways of presenting data. Tables are very difficult and sometimes they're very large. So we resort to the forest plot. But beside the forest plot, in recent science, with this what we call drapery plots. Drapery plots have an advantage over forest plot in that they provide the p-value function. We know there's a lot of contestation as regards to the p-value. The International Association for Biostatisticians are actually contesting that p-value is obsolete. So we need to turn to the p-value function. So maybe in the coming years, we're no longer going to be using the forest plot, we're going to go into the drapery plot. So, but for now, the forest plot is what is of interest to us. So how do we interpret the forest plot? At the end of this lecture, every global neurosurgeon should know how to interpret the results of a systematic review and meta-analysis and translate the information to patient care. So let's take, for example, I will take an example, a clinical example, before I go to an example that involves global neurosurgery, because as clinicians, we have the tendency of understanding things which are closer to us. So we look at the topics such as endoscopic versus microscopic pituitary surgery. We're comparing endoscope to the microscope, okay? And we're looking at complication rate in terms of CSF leak. We have group A, patients with endoscope, and group B with the microscope. It's difficult to draw any conclusion from this table. So if we look at the forest plot that was plotted from this data, how do we interpret the forest plot? The first thing is you need to identify the title. So the title is always defined based on the P-code format, patients, intervention, comparison group, outcome, sometimes the time frame, and then the settings. So we're comparing the post-operative CSF leak in patients operated for the endoscope and then the microscope after pituitary surgery. Secondly, you need to identify the studies and the year the studies were published. It's very important. If you are looking at the meta-analysis that was conducted in the 90s, you cannot apply the findings today, maybe in 2025. So you need to look at the year in which the studies were published. Next, you need to look at what were the intervention group and the comparison group. So you look at the number of events that occurred and then the total number. And then you look at the numerical outcome, because a forest plot gives two kinds of measures, the numerical measure and then the graphical measure. So the information you have on the graph here is the same information you have on that's written here. So you need to look at the two. And then next, you need to look at this weight of the study, because sometimes in a forest plot, a very large study, because it's having a very high power, can actually skew the results. So you need to look, maybe the study is heavily weighted by one study. For example, if you look at the study here with a sample size of here you have 234. See, the study carries a weight of about 47%. So you see that it's going to influence the results of this meta-analysis. Sometimes you have many small studies and then a large study. You can take away the large study, analyze the smaller studies and see the results you have, and then add the bigger study to see how much influence it is having in the overall meta-analysis. Next, you need to define the scale. You need to know what is on the left and what is on the right. In this case, it needs to be defined because there's not a universal or there's not convention that is accepted worldwide as to what has to be on the left and what has to be right. So here we define that to the left of this line favors the endoscope, and then to the right favors the microscope. Next, you need to know what is called the line of the null line here. In terms, when we're talking about if the effect size is the relative risk, we know that we're comparing A to B. So if the risk of A to B is 1, it means that there's no difference between A and B. So you need to know where this line is and know that everything that is to the right is going to be greater than 1. Everything that's to the left of the line is going to be less than 1. Next, you need to understand what these squares and the lines mean. The squares are the effect sizes which are measured. Here we're talking about the complication rate, okay? So the incidence of complication. So it is the square that is represented here, and the size of the square is proportional to the weight of the study. And then the horizontal lines here are the confidence interval. Finally, we get now to the pooled relative risk, the pooled effect size, which we intended to have, because, as I said, many studies were published and there was some discrepancy. Some were in favor of endoscope, some were in favor of the microscope. We wanted to know which direction to take. So we pull these studies together and we get a relative risk, which shows that if you compare the CSF leak in endoscope compared to the microscope, the risk is about 1, which means that it's not different because we see that the pooled effect size crosses the null line. And the 95% confidence interval contains 1, which means that there's no difference actually between the endoscope and the microscope, although we know in clinical practice that the CSF leak is more with the endoscope than with the microscope. The next thing you need to look at is the heterogeneity. Are these studies comparable? Because if the heterogeneity or the difference between the study is very high, okay, means the studies are so different, you cannot combine things which are different. You have to combine things which are similar. So here we see that the heterogeneity is 0. So these studies are combinable. And lastly, look at the p-value. Okay, the p-value is statistically non-significant. So there's no difference, as I said here. The relative risk was 1.19, which with the confidence interval, which includes 1, and the difference is statistically non-significant, again, which is in line with the study which we had. So this is a typical forest plot of a meta-analysis of binary variables. So coming to global neurosurgeons, we are used to looking at the incidence of diseases, the prevalence of diseases, the burden of disease globally. So we know spina bifida and hydrocephalus, these are global health problems. So if we're looking at the incidence of patients that are going to develop, for example, hydrocephalus after spina bifida surgery, then okay, we look at the incidence. So here we're not comparing, we're just going to pull the incidence of studies that have been published in different settings. So we have the years in which the studies were published, the number of children that are going to develop hydrocephalus after surgery for spina bifida, okay? So when we draw the forest plot for this kind of study, the forest plot for unary data, for example, incidence, is a bit different from that of binary data. Again, you need to identify the study, the year in which it was published. Here, you look at the incidences, okay, which is the risk, it's a probability, the weight of the studies and the standard error, the outcome measure, the numerical value, and then the graphical value. Look at the weight of the different studies that were included in the meta-analysis. You have to identify the scale. We know that the prevalence can only vary between 0 and 100. Okay, you cannot have a negative prevalence. So this needs to be well defined. Again, we've already defined what the squares, the mean, and then the bar and the horizontal lines, which are the effect sizes and which are the incidences, and then the 95% confidence interval. And then the pooled incidence. So if you look at the incidence in all these studies, the pooled incidence was 78%, okay? Here, the heterogeneity is very high. It makes sense because, you know, if the incidence of any pathology varies with the population that is studied, the place that where the study is being carried out, and the timing. So this explains why the heterogeneity is very high, okay, and it is statistically significant. Again, I take another example, hydrocephalus again, which is a public health problem. We're looking at the length of hospital stay in children that were operated for hydrocephalus, either with endoscopic TED ventriculostomy or ventriculoperitoneal shunt. Again, this is a kind of forest plot we are going to have here. You see that it is different. Here we are looking at the mean of the length of hospital stay. We need to define the standard deviation, ventriculostomy and the VP shunt. And here we need to, what we pull together is what we call the standardized mean difference. So because we are comparing the length of hospital stay, it has to be the same for measurement for the same groups. We cannot measure the length of hospital stay in days in one group, and the other group we measure in, say, in hours or in weeks. We are not going to be able to pull this data, so we need to standardize it. That's why we call it the standardized mean difference. Again, here, these studies are very heterogeneous with a very high I square, and the p-value was statistically significant. So this is just to show you the different forest plot which we have. We need to understand how to interpret the forest plot before you are able to extract data from it and translate it into patient care. So these are the 10 basic things, the most important things which you need to know when interpreting a forest plot. So once you've interpreted the results of the forest plot, you need to be sure that the results, the findings of the systematic review and meta-analysis are valid. Are they appropriate? Was it appropriate to pull these studies together? Were these studies combinable? Were these studies comparable? So the correct interpretation and critical appraisal of systematic reviews and meta-analysis enhances the appropriate application of evidence to patient care or in defining policies. And there are 4 major tools which are very important before you use the results of a systematic review and meta-analysis to translating into patient care or policies. 1, heterogeneity. 2, modeling. 3, certainty. And 4, bias. What is heterogeneity? Heterogeneity tells us about the similarity between the studies. Okay, it tells us how variable the studies that have been pulled in the meta-analysis are. Okay. On the forest plot, heterogeneity is always defined at the bottom left. So this is where you have heterogeneity, the I square here. This is what you call heterogeneity. So you need to know where you have to look for it. You see many statistical values which are put here. You have the tau square, the chi-square. But what I recommend for beginners in research methods should focus on it, because if the studies are heterogeneous, then they shouldn't be pulled together. You just need to do a qualitative summary. Okay. When the studies do not overlap, we say there is less heterogeneity. If the heterogeneity is very high, we cannot combine the studies. So we can only compare studies which are comparable, and only combine studies which are combinable. And again, you need to know there are different kinds of heterogeneity. There's clinical heterogeneity, methodological heterogeneity, and statistical heterogeneity. Clinical heterogeneity is a concept that tells us that we look at the differences between the patients, the intervention which was given to both groups, the comparison group, and then the outcome. So this, for us to be able to know if there's clinical heterogeneity in the studies that were put in the meta-analysis, we need just clinical judgment. So this is based on experience. When you look at the data, you for example, if you're studying craniopharyngioma, for example, and you are pulling data in craniopharyngiomas in children and in adults, it doesn't make sense because these are 2 population groups. So you need to have if you look at hydrocephalus in children and adults, sometimes it might be difficult to pull the data together because the age groups are different. So this is going to bring about what they call clinical heterogeneity. What about methodological heterogeneity? If you're combining studies where a group of studies, where you have randomized clinical trials, and you also have, on the other hand, observational studies, you can't combine these studies together because combining them together is going to bring about what you call methodological heterogeneity. Again, so, and if you have to do that, you need to understand the statistical methods which you need to use to combine studies of different methodologies. What is much more important to us is the statistical heterogeneity, which is the variation between the studies and between the studies. And I'm going to explain to you how it is very easy and very simple to detect statistical heterogeneity. There are so many methods. The easiest for people who have little or no background in statistics is what we call the eyeballing method. You look at the forest plot. You see that here. These are the different studies, study 1, 2, 3, 4, and 5. They overlap. Okay, so because they're overlapping, so there's less heterogeneity, or we say the studies are homogeneous. I avoid using the word homogeneous because there are no homogeneous studies in research. Okay, the study can only be less heterogeneous or high heterogeneous. Okay, so just by eyeballing, you look at here, there is an overlap. So this study has less heterogeneity. If you look at these studies here, see they are far apart from each other. So the heterogeneity here is very high. So without even knowing the statistics behind it, you can already say the study on study B has high heterogeneity, and the study on the left has low heterogeneity. The next thing you can also do for people who have little or no background in statistics is to use the technique of imaginary line. So you know that this diamond is the pooled effect size. So if you draw vertical lines at the edges of the diamond, which represent the 95% confidence interval, and they cut across all the studies, it means that heterogeneity is very low. If you cut them here, you see that this study, the lines do not touch this study. So it means that here the heterogeneity is very high. Another method, which is very simple for people without background in statistics, is look at the confidence interval. If the lower limits of the confidence interval of the studies do not surpass the upper limits of the confidence interval, it means that there is no heterogeneity. So here, these are the lower limits which are here. None of the lower limits, which is 0.1, 0.5, and 1.4 attains 4.5, 2.1, and 5.5. So therefore, it means that these studies are less heterogeneous. We don't say they are homogeneous, we say they are less heterogeneous. For people with a background in statistics, we look at the statistical values to determine heterogeneity. There are many statistics, and I'm going to caution you, don't waste a lot of time looking at all of them, except in particular cases where you are working with a statistician. So you have the Q statistics, which is p-value, the chi-square, which is p-value, you have the tau statistics. And these statistical tests have a lot of drawbacks because they are influenced by the number of studies included in the systematic review and meta-analysis. They are influenced by the sample sizes. So sometimes they give very wrong values. And again, they are less sensitive. For example, the chi-square test, the cutoff p value is considered when it is 0.01. We know that classically in research, we always consider 0.05. So this makes this test not sensitive enough. So what are these tests? If you look at a forest plot, you're going to see here the tau square, which is here, tau square, which I was talking about. You're going to find it here, which is the first statistical test which is going to be reported. Next, you are going to see the chi-square test, which is also reported here. Okay, and then finally, I'm going to see the I-test square, which is the I which determines the heterogeneity. I strongly recommend that for novices, just focus on the I-square and you can just briefly look at the tau square and the chi-square, but it's not very important, okay, because the interpretation is very difficult. So it's better to focus on what is easy for you. So the I-square test is the most reliable in assessing heterogeneity. And it is very important for every neurosurgeon, especially the younger ones now who are going to practice neurosurgery in the next 10 to 20 years, because the practice of neurosurgery is going to is based and is going to continue to be based on evidence-based medicine. So you need to understand how to interpret and extract data from these systematic reviews and meta-analysis. So to make long short, the I-square test is the most reliable to assess heterogeneity. If it is less than 50%, we say the studies are not heterogeneous. If it is more than 50%, we say there's high heterogeneity. This is very important because if you have to look at the model has to be used in conducting the systematic review. If the heterogeneity is very high, then we cannot use the fixed effect model. If it is very low, we have to use the random effect model. So when the heterogeneity is high, you can use just the random effect model. You cannot use the fixed effect model. But when it is very low, you can use both. So how can you solve the problem of heterogeneity in systematic reviews and meta-analysis? You can, if the heterogeneity is very high, you can just do a qualitative summary of the studies without pulling the data together in a meta-analysis, okay? You can do post hoc subgroup analysis, you can do sensitivity analysis, meta-regression. These are statistical terminologies which should not bother you, okay? The easiest for neurosurgeons is to look at what we call the Labe plot. It is always presented in most systematic reviews and meta-analysis. So you are going to see the intervention group on the y-axis and then the control on the x-axis. Then you are going to see a horizontal, we are going to see a diagonal line which is here. So if the the systematic review and meta-analysis favors the intervention, most of the studies are going to be found on the left side. If they favor the control, they're going to find on the right side. If they're in the middle, then you're going to find it on this diagonal. And you also have to look at the size of the circles. These are the different meta-analyses. If the bigger studies are found on one side, then it also gives you an idea about the heterogeneity. So this is how you explore heterogeneity and deal with it in systematic reviews and meta-analysis. After dealing with heterogeneity, the next thing you need to look at to confirm the validity of a systematic review and meta-analysis is the model. I told you before, if the effect size, if you look at the heterogeneity and it is very large, greater than 50%, then you cannot use a fixed effect model, because the fixed effect model assumes that the effect sizes of all the studies are the same. The goal of this kind of model is not to generalize the results to the general population. The goal is just to apply the results in the setting in which they were conducted. But if you look at the random effect model, here the goal is to generalize the results to the wider population, which concerns global neurosurgeons, because when we look at the prevalence or the incidence of a disease, we want to give an idea of what is happening globally. So it is better to use the random effect model. So studies that involve global neurosurgeons, it is strongly recommended that you use the random effect models. Certainty. How confident are we about the results of the systematic review and the meta-analysis? There's a way to assess certainty. You don't just look at it and say, oh, this systematic review, because it was done in Cambridge, it was done in Harvard, it was done in Stanford, it was done in Italy by Professor Franco Cervede. It means that we have the results are true, and we have so much confidence in it. There are tools which have been developed, validated to check for the certainty. Okay, we have the great tool, which is, although it's hard, when I scan through the literature in neurosurgical journals, very few studies use the great tool to assess the certainty. But I think in clinical epidemiology, it is widely used, and in Cochrane systematic reviews and meta-analysis, it is highly used. So in the nearest future, I'm sure we have to integrate this in the field of neurosurgery. The last thing you need to look at is bias. Bias is systematic difference that exists within the studies, included in the systematic review and meta-analysis. And you have to be very cautious of this, because if a study is highly biased, the results are going to be faulty, and you're going to apply faulty results in making decisions about the patient or about policies. There are different kinds of biases. The bias can stem in from the baseline characteristics of the studies, of the groups included in the study. For example, as I said before, if you're looking at craniopharyngiomas and you're comparing results in adults and children, the age groups are different. So the baseline characteristics are already different. So there's already what we call selective bias. Okay, if we are going to, if you are providing the treatment, and the treatment are different between the two groups, then is what we call performance bias. If in one group, in the follow-up of the patients, there's a lot of loss to follow up in group A compared to group B. Okay, at the end of the day, you cannot compare these studies, because you have to find out why some patients dropped more in group A than in group B. Okay, we talk about attrition bias. Okay, if there's a difference in the assessment of the outcome in group A and group B, okay, for example, if you're measuring the head circumference, we have to make sure that, no, there are some of these parameters in neurosurgery and clinical science where they are subjective. For example, if you're doing an ultrasound, okay, transfontanelar ultrasound, and if it's not done by the same person to measure certain parameters of the ventricles, then there might be difference. Okay, if different radiologists measure it, then there must be a difference in the measurement of the outcome. So we talked about detection bias. Okay, there are all many kinds of biases that exist in systematic reviews and meta-analysis. So we need to look at them and sort them out. Otherwise, we are going to draw conclusions which are not correct. Okay, how do we do this? One of the ways is to look at, we do sensitivity analysis. Okay, so we do a graph. This is a study that was done to look at the prevalence of TBI across many countries. So you see that here, there's a study that is far away from the rest. Okay, so this study is totally different. So when you do a systematic analysis, it tells that there's a bias. So you need to redo the analysis, excluding the study. Okay, and then you are going to have a real effect size, and then you actually comment on the study that was excluded, because this study does not fall in line with the rest of the studies. Another way you can look at it to look at the funnel plot. These are things we always see in papers published on systematic reviews and meta-analysis. So these are practical things which you need to understand. So if you look at all the studies, if most of the studies don't fall below the diagonals of this triangle, then there's a risk of publication bias, okay? Of course, there are statistical tests which I use, EGA, PT, etc., etc. You don't need to know most of these tests. You just look at the p-values and see if they are statistically significant or not. But you need to look at at least the sensitivity analysis and then the funnel plot. This is going to give an idea about the bias. So if both the heterogeneity and bias are absent, then 95% of the studies are going to lie within this zone. Then we can say the meta-analysis is not biased and the results are we are confident about the results. We can then apply it to patient or developing policies. So how do we appraise a meta-analysis to translate the findings into patient care? There are a number of questions which we need to ask. Why do we need to do a meta-analysis, a systematic review, and a meta-analysis in the first place? We conduct it when we have smaller studies and we want to pull the smaller studies together to get a larger sample size. Larger sample size means that the power of the test is going to be increased, and therefore we can generalize our findings. We can do a systematic review and meta-analysis to bring these studies together and do subgroup analysis. For example, we can look at the prevalence of, say, spina bifida globally, and then we do subgroup analysis for Africa, for Latin America, for Asia, for North America, for Europe. Then, so the systematic review and meta-analysis permits us to be able to do this. You have to be very critical. Does the meta-analysis make sense? Were the studies comparable? Does it make sense to pull the studies together? These are questions you need to ask. Okay, but you see, these questions I'm asking are subjective. They are objective tools that have been developed by clinical epidemiologists to assess the quality of systematic reviews and meta-analysis. There are tools that have been developed to look at the methodology of systematic reviews and meta-analysis. There are tools that have been developed to look at how they have been reported. And then there are tools that have been developed to look at the risk of bias, which I just described below. So quite recently, with systematic reviews and meta-analysis of Cochrane, the Cochrane group, they have developed other tools, not only to look at the methodology and the reporting of the systematic review and meta-analysis itself, but they're also looking at the risk in the studies that were included in systematic review, because I'm going to demonstrate very shortly that if the primary studies that we pulled in the systematic reviews and meta-analysis are biased in the first place, it's going to produce biased results in the final meta-analysis. So we need to assess all this. Once this is assessed, we have to now apply the results of a systematic review and meta-analysis to patient care. And to apply this, we need to understand the concept of evidence-based neurosurgery, which I said before. It is the integration of the best research evidence, the practitioners' expertise and experience, okay, the preferences of the population to apply, to develop good policies to apply to the population. This requires a lot of work to do, okay? And we have to understand that in applying the principles of evidence-based neurosurgery, we don't have to forget clinical and the statistical significance of the studies we find. We have to consider cost, okay? We have to look at the risk and the benefits of applying the findings. So it's not because we've had the results of a systematic review and meta-analysis that says A is better than B. So we just have to jump into applying it to patients. We have to look at cost. We have to look at the benefits and the risk. We have to look use our clinical judgment to see if it actually makes sense. So once this is done, we can then apply now the results of systematic reviews and meta-analysis to our patients. So what are the challenges of conducting systematic reviews and meta-analysis for global neurosurgeons? What are the challenges in interpreting systematic reviews and meta-analysis? And what are the challenges in applying them? A few years back, we published a series of papers where we look at the quality of primary studies, okay, in neurosurgery, and we realize that there's a significant misclassification of studies in neurosurgery. So we know again that a systematic review and a meta-analysis is an integrative study which results from the pooling of the primary studies. So it is the misclassification of the primary studies. We are definitely going to have biased or faulty results in the meta-analysis. So that is why in the paper that was published around 2014, assessing the quality of systematic reviews and meta-analysis in neurosurgery, it was proven that about 1/3 do have nothing to do with the definition of systematic review and meta-analysis. And this is very critical. We propose, of course, solutions to this, but it's very simple. Many clinical epidemiologists have developed tools that are going to help global neurosurgeons who are interested in this domain to know how to conduct a systematic review and how to report it and how to critically interpret it and apply the findings to patient care or in developing policies. So these are some of the tools. You can just go to Google and type on Equator Guidelines, enhancing the quality and transparency of health research. All the tools are available there. Again, there are problems in systematic reviews and meta-analysis are not only related to the quality of the studies involved, there's also a problem of disparities. You know, a common example which is always presented by Professor Franco Savada is the question of traumatic brain injuries. We look at the Brain Trauma Foundation guidelines. More than 80% of the studies there come from high-income countries, okay, and very few come from low-income countries. So when you pull the studies together into systematic reviews and develop guidelines based on studies coming from a particular geographical areas, then the results are not generalizable. So therefore, there's a need to encourage the publication of studies across the globe. And Professor Franco outlined in this paper, which he said, journals have a very big role to play, okay? Journals need to operationalize global neurosurgery research. It is when journals do this that we're going to have data globally, and we're going to be able to pull data across different settings and produce systematic reviews and meta-analysis and guidelines that are applicable across the world. And we've been doing it in the Journal of Global Neurosurgery, and this is the reason for which it was even created. We created it because we wanted to curb this inequity that's existing between high-income countries and low-income countries. So we are doing just that. Many other journals are doing it. The Red Journal created a section for global neurosurgery. The World Neurosurgery has done so. And recently, many journals have become open access, okay? And the goal is to ensure that researchers in low and middle income countries are able to publish our paper and have access to data, so that when we develop evidence-based guidelines, we have to include data coming from all the parts of the world. So I'm going to illustrate to you the abuse, misuse, and application of systematic reviews in global neurosurgery. You know, Freeman stated that the greatest advances in sciences usually result from new tools rather than from new doctrines. Okay, so we define global neurosurgery as the clinical and the public health practice of neurosurgery. And you've noticed that from the beginning of my presentation, I'll be using examples with the pituitary surgery. A few years back, there was introduction of the endoscope. Pituitary surgery was done mostly by the microscope. So when a new tool was introduced, there was a need to test for this new tool, okay, to see which of them is going to provide better results in terms of gross tumor resection, visual outcome, hormonal remission, okay? So when you look at this example, the studies published after the introduction of the endoscope were controversial. There were some of the studies saying the endoscope is better than the microscope. Others were saying the microscope is better than the endoscope. Others were saying this is equivocal. And this resulted in the conduct of about 10 systematic reviews and meta-analysis. And this one of them was my master's thesis when I was doing my neurosurgery. And when I went through these studies, there were 73 studies that have been included in all these meta-analysis. 32% of them were termed retrospective study. There's no study design called a retrospective study. It is inappropriate. You don't know if it is a case control study. Is it a cohort study? Is it a case series? So it becomes very difficult, because when you just say it is a retrospective study, it becomes very difficult to know, because I showed you before that is what we call methodological heterogeneity. So if we don't know this kind of study design we are having, then it's difficult to pull the study together. So we need to be very meticulous and accurate in writing the study design. The next thing is that among these 73 papers, 52% did not even report the study design. So somebody conducting a meta-analysis and systematic review meta-analysis wouldn't even know what kind of study design was used. So it becomes very difficult to actually pull these studies together. So this meta-analysis was conducted and it was published, okay? And you can see it has been cited up to 400 times, okay? So this is a meta-analysis whose conclusion is wrong. It is inappropriate, and it was done in one of the big centers by a very famous neurosurgeon. When you look at what their conclusion was, that the vascular complication rate was higher in the endoscope than in the microscope, okay? And you realize that the guys who conducted the study just got a number of studies, both descriptive, analytic, randomized clinical trials, and pooled them together in what we call apples and oranges, and then they came out with a value. This is not correct. This is not how a systematic review and meta-analysis should be done, okay? This is what they told us. They told us that the risk of vascular complication was 3 times more in the endoscope than in the microscope, and the p-value was highly statistically significant. But again, when I tried to analyze the studies, we realized that of all these studies that were included in the meta-analysis, only 4 of them were analytic. That is, they included a comparison group. 21 of the studies were descriptive studies, that is, without a comparison group. And it becomes very difficult. You remember when I was talking about proportion meta-analysis, for example, incidence, the heterogeneity is going to be very high. if you don't compare something to another, it's difficult for you to draw a conclusion. You cannot draw causality. It's difficult to establish a correlation and causation. So therefore, when we extracted just the studies that were comparative, okay, there were just 4 of them, we realized that actually there was no difference in the vascular complication. Okay, the vascular complication in the endoscope compared to microscope was actually, there was no difference. So we concluded that in conducting systematic reviews and meta-analysis, only compare studies that are comparable and only combine studies that are combinable. So to conclude, global neurosurgery is the clinical and the public health practice of neurosurgery, okay, with the goal of providing safe, affordable, and timely care to people in need, okay, and it should be based on the principle of evidence-based medicine. Talking about evidence-based medicine, we know systematic reviews and meta-analysis and guidelines form the basis of evidence-based neurosurgery. Systematic reviews and meta-analysis are found at the pinnacle of evidence-based ladder hierarchy. So we need to know how to interpret them. Even if we don't know how to conduct them, at least we should know how to interpret them. By so doing, we will be able to translate information in systematic reviews and meta-analysis to patient care. So the key message here is that every global neurosurgeon, even if he or she doesn't know how to conduct a systematic review and meta-analysis, should know how to interpret and how to apply the findings to patient care and in developing policies. Thank you so much.
Thank you, Ignatius, for the motivated and outstanding and complete presentation. I'm seeing if there are any questions. Yes, there are. I think can you read by yourself the question, or you want me to do it?
I could also help with the questions.
Yeah, go ahead.
Yeah, so I think the one that is directly, or some of the ones directly related to your presentation is from Kingsley Annie. So he thanks you for the presentation, and then he asks, in the modeling, can a work be with fixed effect modeling be converted to random effects for interpretation and application to the general public?
Sorry, I didn't get the question.
So can you convert from fixed effect modeling to random effects modeling in order to generalize the results?
Can you convert from fixed effect model to random effect model?
Yes.
Yeah, so as I said, the first thing is you have to know when to use a fixed effect model and when to use a random effect model. If you have doubts, use a random effect model, okay? Of course, there are some statistical tools which you can use to convert, but this is for people who are well-trained and in statistics who have some strong background. I'm a neurosurgeon, so I just know basic statistics which I use to help me provide care for my patients, but it's possible.
Yeah, so he also asks if which one is easier to do, the random effects or the fixed effects?
It's not like which one is easy to do. You just have to choose. When you are drawing the forest plot, okay, when you are selecting the parameters to draw the forest plot, depending on what you want. Once you've seen that the heterogeneity is very high, you can then, if you did your initial systematic review and meta-analysis with the fixed effect model, and you realize that the heterogeneity is high, then you have to use the random effect model. So you are the one to determine when you are doing the statistical analysis and when you are drawing the forest plot.
Yeah. Then his other question is about forest plots. So I think you already touched on this, in your explanations about how to read forest plots and what to do when there are outliers. So but maybe you should reiterate it again. So he asks, what do you do when the forest plot graph is not as complete as the ones you depicted?
Well, the ones I showed, I used, because when I looked at the literature, I went through a number of systematic reviews and meta-analysis that have been published in Global Neurosurgery. There was really, I'm sorry to say that I didn't see one that was really ideal for me to use to illustrate the concept. So that's why I developed this hypothetical example, so that people actually get the concept, and the different steps which you need to know. You can then, from these standard forest plot which we represented, you can then try to adapt it to the different studies, which it's difficult to see a systematic review, a meta-analysis that is very complete. There are always going to be some flaws.
Yeah. Adedoyin Alao asks about your views on scoping reviews.
Yeah, scoping reviews and systematic reviews. I showed you that the family of reviews is very broad. There are so many kinds of reviews. And as I said, it starts from the traditional reviews. Okay, sometimes they call the comprehensive reviews or just the literature review. They go now to the scoping reviews, the systematic reviews, and then the particular kind of systematic review, which we call the Cochrane systematic review, which is of very high quality. So the major difference, maybe the trick is to distinguish between a scoping review and a systematic review. Okay, in terms of focus, the systematic review focuses on a very clear, specific question. Okay, whereas the scoping review, the question is always a bit broad. The goal of the systematic review is actually, if possible, to do a meta-analysis, is to narrow down and answer, provide a specific response. With the scoping reviews, you are trying to see the gap. Okay, from the gap which you are going to detect with the scoping reviews, you can then help you now to do maybe a systematic review and a meta-analysis. But a systematic review takes time. It takes months to do a systematic review and meta-analysis. Scoping review is lesser time. In terms of assessment of quality, with systematic reviews and meta-analysis, you need to assess the quality of the study. Okay, there are stringent criteria which you need to use. With a scoping review, nobody might penalize you if you don't use quality assessment tools.
So I think those are all the questions that are directly related to the presentation. There are a few others that ask about how to get into global neurosurgery research. Yeah, I think maybe any of the other panelists could answer that.
Well, that question should be asked Franco, yeah.
Yeah, well, I just have a couple of questions for you. I mean, very good presentation. And as I told you before, we need to clarify the conjunction between methodology and clinical assessments and clinical utility. And you have done a good job. I am asking you three questions. The first question, what you call scoping review, that maybe we will call a narrative review. A review is not based on a systematic review, but may be helpful because it gives you a rough idea of where is the topic and where we can move for further study. So your opinion about the narrative review. Second, keeping the fact that not necessarily what is done with good methodology can be applied in our daily practice. I give you an example. There has been only this year, the past year, 2024, 3 clinical randomized studies on embolization of chronic subdural hematomas. You know, embolize the middle meningeal artery to avoid the bleeding from the membranes. The studies have been pulled together in spite of the fact that the entry criteria were totally different. I give you an example. One study, they compared 2 groups of patients operated, one with embolization and one without. Another study compared groups of patients embolized on patients operated or not at discretion of the surgeons, and these were put together. But this is not the issue. The issue is chronic subdural hematoma is one of the most frequent neurosurgical surgery that we have all around the world. Can we believe that it will be helpful to tell everyone that we should embolize everywhere, every patient with a chronic subdural hematoma? Obviously, is unfeasible. We cannot do it because it costs a lot of money, because in many parts of the world, including our countries, there is no one who can do it. And third, because we have complication. So copying very well conducted studies can lead to a clinical, let's say, confusion, because we want to do what the other do, but simply we cannot. So in a way, we need to stratify the suggestion and say, listen, this suggestion is at this level, which is also not true, because we know that in US, for instance, some technically demanding procedure like embolization are done only if you have an insurance who can provide the embolization. If you don't do it. So generalizing these studies is, in my opinion, dangerous and not in favor of a global approach to neurosurgery. The third and the last comment, because I have in my switchboard now in my computer, I am reviewing a paper with a systematic review of the complication of cranioplasty and a pooling analysis of the data published. As you said before with the example of the endoscopy, we know that many complications are not in the first 2-3 months, are later. But this study compares papers published with a follow-up of 3 months versus papers with a follow-up of 3 years. So obviously that's not working. Or, for instance, we have materials where we had much more patients studied, 1,000, and materials where we only have 40 patients studied. Obviously, it is almost impossible to put them together, because we know that if you have 40 cases, the risk of not having complication is not the same as when you have 1,000. So, in a way, I need your comments about, do we really need to stack only on systematic review, or you find a role for narrative non-systematic review? And the second thing, second and third is together. The final target, its applicability of what you are suggesting. What do you think?
Thank you so much, Professor Franco, for all the questions. When you look at evidence, every evidence has has a place in the practice of medicine. Okay, in neurosurgery, we are surgeons. Not all the things we want to study can be studied in randomized clinical trials. So there are some things that are going to be studied just using maybe from cohort study. So information from cohort study and lower studies can provide us adequate information. So for example, if you look at, say, for example, in orthopedic, the hip arthroplasty, it was never validated in a randomized clinical trial. It was a cohort study. Reviews and meta-analyses are the pinnacle. It doesn't mean that we have to use these kind of studies all the time, but when it is available, we should use it. So narrative reviews are very important, as you said, because narrative reviews are usually, they shouldn't be written by any kind of person. I see many medical students and people who are not even in the field of neurosurgery writing narrative review. No, a narrative review should be written by an expert in the domain. For example, we can invite Professor Franco to write a narrative review on, say, traumatic brain injury. You are putting together your expertise and experience over the years, okay? Putting together all the research evidence that's available to provide this evidence. It must not be a systematic review or a scoping review, but a narrative review can sometimes provide evidence or provide information that is very important, but who is writing the narrative review is the question. It should be done by an expert in the field, but not just by somebody who doesn't even understand the subject matter. Concerning the question about generalizability and globalization with the embolization, when I mentioned that only compare studies that are comparable, only combine studies that are combinable. So if the surgical techniques are different, in group A, they're using embolization and non-embolization. The other one, they're using embolization and surgery. It means that the techniques are different. So you cannot even pull them in a meta-analysis. You can just do a narrative summary of this without doing a meta-analysis. A meta-analysis has a clear, defined question with the outcome well-defined. And this takes us to the next question about with the one you're talking about, cranioplasty. If in some studies the outcome was measured at 3 months and in some other studies was measured at 5 years, you cannot combine these studies together. You have to take a minimum a point or the endpoint where you used to measure the outcome. So the outcome has to be the same for the studies which you have to pool, and the endpoint has to be well defined. If the endpoints are different, okay, then you cannot pool these studies together. So you need to consider all these factors. That's why I said, having conducted systematic review and meta-analysis, you need to check for the validity, and in the validity, you need to look at the similarity between the studies. When you talk about heterogeneity, you need to look at the models which was used. You need to look at the presence and absence of bias. You need to look at the certainty. Then you have to look at the cost, the risk, and the benefits. So you need to put all these together before applying the evidence to the patient. So it's not just about the systematic review and meta-analysis. It's a whole, it's a way of thinking. It's a paradigm shift in translating information to patient care that involves a lot of parameters.
I think there's one last question from Bella Connor. Bella is asking about misclassification, whether that's considered a bias. And secondly, what bias can exist when we don't take equal number of cases and controls in a case control study?
By Rooney. Oh, Rooney, thank you so much. No, Rooney was co-author in the paper. We actually started it together. So misclassification is something which is very, very, very critical. For example, when you look at evidence-based hierarchy, you have the randomized clinical trials. Next, the cohort, the case control studies, okay? And then you have maybe the descriptive studies and then expert, the opinion at the bottom. So if you misclassify a case control study for a cohort study, it means that you have upgraded the study. You see, so it is some form of bias because you are putting at a higher level, whereas the quality of the evidence provided is low. Similarly, if you take a cohort study and label it a case control study, then you have downgraded the evidence. So when you look at the grade criteria, where you're looking at the certainty of the studies, sometimes evidence is upgraded, sometimes evidence is downgraded. For example, if you take a randomized clinical trial that is poorly conducted, and then a cohort study that is well conducted, they might be of the same level. Even though we know that randomized clinical trials are supposed to be at the top of the hierarchy and cohort studies are supposed to be at the bottom. So it is about, again, critically analyzing them and analyzing the risk in the different studies before combining them into systematic reviews and meta-analysis.
There's another comment from Nuruddin, though it's not a question, but mainly commenting about narrative reviews and how we could how that could be beneficial in many studies, because it brings in different papers, different articles that cannot be analyzed together in a systematic or a fashion, or maybe put into a meta-analysis, but basically bringing those diverse literature together. Do you have any comments on that?
Well, that's why what Ignatius said. I mean, that's why narrative review should be done by experts, by people with a lot of experience. Cannot be done. The systematic review can be organized by students, by young neurosurgeons, because there is a method to follow. The other one is based on experience. So the weight of the papers to be included, it is a summary of a long experience. So I agree, this should be done by real experts, probably together with young neurosurgeons, but the leadings are experts. Well, I think, sorry, I think it's finished, but anyway, I have to go because I am in the middle of 2 trains. So I just thank you all and my best wishes to everyone. Goodbye.
Yeah. Franco, there was a question. Somebody asked how to get involved in global neurosurgery. Maybe you answered that before.
Yeah. Well, we receive quite a lot of, I think is a question to discuss with Ernest. Ernest, you are still here or? Maybe,
I'm still here.
yes.
No, I'm here. Yeah.
Oh, okay. Ernest, this is a key questions. I'm getting when I do presentation, and I think it's the same for all of you. When I'm traveling and doing presentation, I found enthusiastic students. I found enthusiastic trainees who want to be involved in the field and publish in global neurosurgery. But we don't, obviously we can involve in our own research, but maybe, Ernest, we can be more ambitious. We can, in a way, collect them and have a proper discussion and starting to do projects with them. I mean, altogether, we find some areas of interest. We find a list of possible collaborators and we put them together, because only this week I had 2 requests.
Yes, I completely agree, Franco, and I'm here although I haven't figured out how to get my video to show up again. But in reply, I'll say that Mission Brain and some of the Mission Brain leadership we've had involved in our research group has been, I think, a very powerful driving force for providing an entree, an introduction, an opportunity for people to get involved with global neurosurgery research, who who don't have prior experience, may not have the mentors they're looking for. I think the kind of initiative you're talking about, Franco, is something we should take up in our group and then maybe look at it with Mission Brain to see how to operationalize it. I think it's a great idea. Yeah.
Okay. Goodbye. Sorry.
Yeah, thanks for joining us. Or rather, scoping reviews. I've found that scoping reviews, which, by the way, increasingly do have a number of recommended tools for quality assessment of included studies. I think they have a major role in global health research and global neurosurgery broadly because of the major data gap that we deal with in particularly from low and middle income countries. And scoping reviews can provide a means of getting a sense for the scope of the literature in a topic or area where there aren't enough controlled studies of a particular research design with sufficient homogeneity for the sort of rigorous statistical analysis that Ignatius spoke to us about. They can be an excellent starting point and a more systematic way. They are a type of systematic review. In fact, some people use the term systematic scoping reviews. They can be a great way actually for more novice and younger researchers who don't have the kind of experience we alluded to for narrative reviews to screen the literature under the guidance of more senior authors to figure out, well, what has been written about this topic, and what sorts of studies have been done, what are their strengths and weaknesses, and they can be richly informative and hypothesis generating as well. So I find them to be a very important part of the global neurosurgery research armamentarium. And the last thing I'll say about scoping reviews is for those who are not aware, I mean, there's a number of organizations who provide criteria for the most rigorous version of the various forms of scientific reviews, such as the Cochrane Group, right? Well, in the nursing education space, the Joanna Briggs Institute is probably the most renowned organization I can think of that provides comprehensive criteria for how to generate scoping and systematic review protocols, as well as the reviews themselves. So there's a lot of free resources and wikis out there for how to start doing this. And again, really great contributions to the literature can be made following those recommendations. All right. We've got a few more minutes. Any other comments, questions, reflections on this topic? I think we've addressed everything in the Q&A. Saad Javed had some questions. Can you please suggest some research labs working on global neurosurgery, which someone can join virtually? Would love to play my part and engage with like-minded people and boost Pakistan Global Neurosurgery Initiative on a global scale. Well, Saad is very plugged in to a number of efforts. I think the question is relevant. I think the initiative that that Professor Servade mentioned is one way. I can't say that I know of labs in global neurosurgery that are sort of functioning exclusively virtually. But Mission Brain right now is my go-to organization for young aspiring neurosurgeons and neurosurgery trainees who want to get involved in the field. PhD opportunities in global neurosurgery. I don't know of any PhD opportunities in global neurosurgery per se. I do believe I came across, and then Alvin, chime in if you're aware of any other such programs. I came across a PhD in global health, I believe at the University of Washington. I think I did see that, Seattle, and I know there's a few others. Ignatius, you're nodding. Do you know of any other such programs, PhD programs that people might be interested in?
No, I think there are programs in global health, but not really. The issue is, neurosurgery is just a small part, a very small part of health. So because we are neurosurgeons, we think that it is so big, but the whole concept is about the global health. They narrow it down to global surgery and then global neurosurgery. So I don't think, there are very few universities that are going to offer such a course. So I know of none.
Right.
Yeah, I think I agree with Ignatius. So most institutions really focus on global health, and some of them may call it international health instead of global health. And sometimes it's also located in institutions with public health named, faculties. So there may be a global health or global surgery track or pathway within the public health pathway. I haven't really come across anyone with for that is specific to global neurosurgery. And then I think some of the challenges sometimes would also be that we don't really have a lot of neurosurgery faculty, working within that public health space. So even when a neurosurgeon, a neurosurgery trainee applies, and intends to do a project in global neurosurgery, they need to find a faculty who has the background, to supervise the students appropriately. And if they're unable to find a faculty with that background, then the students may not get in. So I think that's a challenge, and that's something that maybe we should also think of in the global neurosurgery arena to try and place ourselves within these public health, global health institutions.
Yeah, completely agree. And as I'm looking at some of the other similar questions, how do I get into research? It's been challenging to do that. Let me see. Yeah, those are the principal questions. Oh no, there's also one about SAFNA, Sub-Saharan African Future Neurosurgeons, working on issues for medical students, residents, and young neurosurgeons. Great resources. The comment I was going to make is, I think it's always helpful to start with whatever public health, and global health faculty you may have available to you in your context, as a starting point. And then, if you got here, then you are likely on some network or social media platform where you have access to announcements about events like this one. And you'll meet a lot of faculty like us and others who are in these fields. You should reach out to those faculty. For people who are asking questions, sorry for the background noise. My kids are in the same room as I am. For people with questions about how to stay informed, apprised about future journal clubs like this, whether there are apprenticeship opportunities, clearly there's interest in engaging with this. What I would recommend you do is, because you registered for this event, you got my academic email address which is provided as a way to send any questions. Use that to send your questions, because we do actually look at how we can expand our engagement in the ways that you're asking within the research subgroup of the Global Neurosurgery Committee. Okay, so we may not have these pathways in place yet, but hopefully you can see that we're very interested in figuring out how to put them in place for you. Okay. Any other final comments from Dr. Ignatius, Dr. Alvin?
Final comment. Well, the future of medicine is focused on the paradigm shift of evidence-based medicine. And we already know what we are supposed to learn. If the older generation maybe have difficulties in conducting systematic reviews, the newer generation shouldn't have that difficulty, because we have with the advent of AI and other development of information and technology, I think it becomes easier now to do some of these studies. So I would strongly recommend that for people that are really interested in global health, you should learn how to conduct a systematic review. They should know how to interpret them and translate the information to patient care and developing policies for a better world.
Excellent. Thank you. Alvin, any comments?
Yeah, thank you very much, Ignatius. Excellent presentation as always. And thanks, Ernest, for the leadership, and of course, Professor Savadai for the great moderation. And of course, we thank all our guests, attendees. So very engaging questions and illuminating presentation. Thanks, everyone.
Awesome. Thank you all. No research presentation.
Thank you so much.
No research presentation would be complete without a shameless invitation to participate in a survey on publication bias. So if you would be interested, and a group of researchers collaborating from these institutions are trying to explore the nature of publication bias and how to advance equity in scientific publication. With that, I will get this on YouTube. Thank you again, everyone, and we will see you in a couple of months.
Thank you.
Here.
Bye.
Bye-bye. Yeah. Nice weekend.
You too.